Business and Local Government Data Research Centre, bringing data to life. Exploring data, enhancing knowledge, empowering society.
Good morning everyone and welcome to HTN Now January. This is the first live session today. We've had some great presentations yesterday from Ideal Health and NHS X, from which the recordings will be on the HTN website later on. This session is being delivered by Dr. Smruti Bulsari, Senior Research Officer at University of Essex, and Laura Brooks, Outreach and Publicity Officer, ESRC Business and Local Government Data Research Centre, on same data, different results, how different methods of analysis in health can lead to wildly different results and the impact this can have on how healthcare is delivered. The next session today is at 1 p.m. from Cardiff and Vale UHB on eye care digitalisation and how they delivered shared care with more than 5,000 hospital patients being seen in primary care during COVID-19, and how they are delivering a primary care electronic referral portal and testing the water of artificial intelligence to manage eye image referrals. So thank you very much for joining us for this session, and over to you, Laura.
Hi, thank you so much, Emma, and thank you again for having us back. It's the second time we've been with HTN, so it's always a pleasure. And today we're talking about how the same data can lead to different results and what this really means for the NHS. So I'm going to run through today's agenda. We've got a really good one coming up. I'm going to give you a quick introduction about us, the Business and Local Government Data Research Centre. Then I'll be handing it over to Smruti, who will be giving you some background information on the data background for healthcare. And then we'll be moving on to 2 case studies, a summary, and then we've got live Q&A at the end. Don't forget to follow us online. You'll find us on Twitter and LinkedIn. But if you want to tweet us today, ask any questions over there. And also keep up to date on what's new in the world of data analytics and research, and some exciting news coming up very soon on what you can expect and some more grant-funded opportunities. So we are the Business and Local Government Data Research Centre. We are part funded by the Economic and Social Research Council, as well as Essex University. And together we support organisations across the UK to use data more effectively. We work with the private sector, the public sector, and the third sector to help them make a real impact. We combine fundamental research with applied to influence policy that informs practice. And what does that really mean? It means that we're supporting the research community to connect with you to bring your projects to life. How we can help is we offer grant-funded data analytics. We offer training, events, webinars, and a consultation to help you find out which of our programs is going to be most suitable for you and your needs. We have 3 core themes, one of which is exploring data. We achieve this through 2 means, which is our Data Analytics Innovation Voucher. Now, you may be wondering, what is a Dave? And it is, yes, a lovely character from a film we all know, and it is also a TV channel. But we're not actually talking about either of those, obviously. We're talking about an innovative way to help organisations benefit from academic expertise and researchers from our centre, as well as our wider network. And this is a grant-funded programme where you would submit a project and we would complete it if approved. As I said, it is funding, it's research expertise that give you the solution you need to make a change within your own organisation, provide useful insight, or influence policy or practice in some way. I could share so many case studies with you from the NHS, from commissioning through to actual service delivery, through charities and all sorts. But I wanted to point one out in particular, which is East Sussex Highways. Now, they were collecting a lot of data about the deterioration of their pathways. They wanted us to analyse that data, to create an algorithm that applied data science to help them predict when potholes were actually going to occur. And that's exactly what we did. And as a result, we've saved them time and money. We applied research expertise in data analytics that they would never have had access to before. Also new to 2022, or it was first launched in 2021, but it will be back in 2022, is the Data Science and AI projects. This is a really exciting scheme where you can access the next generation of data scientists and artificial intelligence experts by having your very own master's students complete one of your projects applying the most innovative data science and AI techniques. It's a rapid funding round, so look out for the launching imminently. The reason I mentioned the East Sussex Predictive Analytics Project was because I wanted to highlight that if we could apply the same methods of predicting potholes in roads to the decline in mental health of service users, imagine what that could do for patients in need. Imagine if we could catch them before they fall, just using the data you hold. That's an example of a project that we could complete. If you've got the data and a need, we could well have the expertise in data analytics to help you bring that project to life. But moving on from that, we can enhance your knowledge by providing training, workshops, and much, much more. We can empower society by closing the gap between academia and policy. So we want to make a systemic change across the UK. We want to help people, help organisations, and derive useful insight from the data we are all collecting every day. Now, you know a little bit more about us as a centre, so please do contact us if you'd like to find out more about the training, the data analytics innovation vouchers, the master's students, or anything else we provide, and we'll be more than happy to help you. So it gives me great pleasure now to introduce our expert, Dr. Smruti Bulsari. She has areas of specialism that include data science, social science, and programming. I would like to highlight that she is an award-winning researcher and now works for the Business and Local Government Data Research Centre. She has a career spanning over 16 years where she has specialised in gender and health inequalities, human development, early childhood education, public health, and much, much more. She's taught in various areas and co-authored books and continues to present her work on public-facing talks, which relate specifically to empowering women and their health. So over to you, Smruti. I'm really looking forward to what you've got to present today.
Hello, everybody. Very good morning to everyone who has joined from UK. There are people from other parts of the world as well. So a very good afternoon and a very good evening to all of you. Thank you very much, Laura, for a generous introduction. Thank you, Emma, for inviting me to speak on the topic. So continuing with the agenda, I would start with the background, which would cover the key challenges when understanding data analysis results, the difference between same data and different data set, and very interesting Fisher controversy. I would then be taking over to two case studies. First is about the hypertension, how same data leads to different results, and what to do about it in that case. And the second case study is about diabetes, blood glucose, high blood glucose, and its impact on different microvascular diseases. And towards the end, I would summarize in the form of challenges and solutions. And the second half of the summary, that is future opportunities to access grant-funded analytics, would be discussed again by Laura, which would be followed by questions. Laura came up with this very interesting quote of Albert Einstein. It says that insanity is doing the same thing over and over and expecting different results. While, yes, insanity is doing same thing over and over and expecting different results, provided you are doing the same thing. And this reminds me of one interesting anecdote which appeared as a part of one of these kung fu movies, and it is popularly known as the Legend of Tai Kwai, wherein a young boy, very young, 5-6-year-old boy is joining a kung fu school to learn martial arts. And on the very first day, the kung fu master asks him to, tap his hands like this on a barrel of water. I mean, the barrel is full of water and he's asked to tap his hands on water. The legend is called Slapping the Water, the Legend of Tai Kwai. He continues to tap the water for the entire day as he has been instructed. And the next day, again, the master tells him to do the same thing. This runs into days and then weeks and then into months. And this goes on for 2 long years. For 2 years, he is doing the same thing over and over again. And finally frustrated, one fine day on a dinner table, he gets very angry at his master and says that, I am not here to do this exercise. I am here to learn Kung Fu. And he hits hard on the table, just to everybody's surprise, including his own, that the table breaks into 2 parts. Yes, the point that I trying to make is, apparently he was doing the same thing over and over again, but the pressure with which he was tapping the water initially was out of obeying his master's instructions, then out of curiosity that why my master is asking me to do this, then out of routine he did it, then he got depressed, then he got frustrated, he got angry, the confounds kept on changing, and that determined the impact with which he was, tapping the water. So apparently he was doing the same thing, but now I would change it. He was doing the same action, he was not doing the same thing, and therefore we got different results. So what? I mean, if we do the same thing and we get different results, yeah, that is what today's talk is all about. But before I move on to discussing what is same data, I would like to introduce some of these terminologies, that is data, analytics, and results. Data is a very, very wide term. Initially, data was conceived to be made up only of numbers, and eventually it happened to be a combination of text and numbers. But now in the era of social media, information explosion, search engines, data has not only remained confined to numbers and text. Data is not only available in the form of structured format, as in the form of tables used to be a couple of years or a couple of decades back, but data could be structured, could be unstructured, it could be numbers, it could be text, it could be a combination of those. Data could even be pictures, data could even be sound, data could even be a combination of pictures and sound, it could be videos, and all this constitutes data. Coming to analytics. Analytics and analysis are often used interchangeably, unknowingly albeit, but analysis and analytics are 2 different things. And our center specializes in analytics, which is a much broader term than analytics. Analysis is basically a subset of analytics. But what distinguishes analytics from analysis is that analysis looks into the data, analysis looks into the past data and tries to, examine the association between variables and tries to look at the patterns. But analytics makes use of the same data to look into future. And as Laura mentioned about one of our projects about predicting the potholes. Yes, analytics does precisely the same thing, that it helps predicting something that is going to happen on the basis of the data which is analyzed. Moreover, analytics is more of a system and analysis is more of a process. Coming to results, there is a difference between results and outcome. Going back to that story, the anecdote of that small boy who was learning, who went to learn Kung Fu, the outcome, the result was that he could break the table into two parts. The outcome is that his muscle strength was developed. This is the difference between outcome and results, and it is important to distinguish this outcome and results, as we will see in the talk later. What is more important is what are reproducible results and why results have to be reproducible. Now, results have to be reproducible in order to generalize. And why do we want to generalize? Because if we are policymakers, we want to implement a policy or devise a policy on the basis of the generalization. And if we are doctors or healthcare professionals, we would like to prescribe a treatment on the basis of what can be generalized. And therefore, reproducibility is very important. So what is this reproducibility? Again, taking you back to the anecdote of that Kung Fu, this method of tapping water is now become an approved method of building strength for those who are learning Kung Fu. Why? Because this, for all the students of Kung Fu, it was found that tapping the water builds up the muscle strength. Reproducible results in technical terms could be said that using the same data, the same data definitions, the same models, you should be able to come up with the same results. So that is reproducibility, and reproducibility is important for generalizing. Generalizing is important for policy making or prescribing the treatment. Okay, this I think I already discussed. So moving on to the next. Why are data important in healthcare? There are many reasons why data are important in healthcare. One, it could give a basic idea, what is called the baseline analytics. It could give a basic idea about what is happening in this pandemic situation these days, and the dashboards that are created to give information about the pandemic situation. That is what basically is baseline analytics, which gives the government to take decision on whether to impose restrictions or to withdraw the restrictions, and whether to, open the borders or not. That is baseline analytics. I would not be able to describe all these aspects in detail, but it is important to know that data is important in healthcare for a lot of things, like planning for care professionals, predicting the demand for doctors, predicting the demand for healthcare professionals, predicting the demand for the medicines or the vaccines or whatever, managing risk, commissioning drug development, so on and so forth. I'm not reading out all this, but yeah, there are a lot of applications of data analytics in healthcare. Yeah, why results from data are important in healthcare is also discussed, that it helps in strategic planning and procuring services and procuring medicines and monitoring, evaluation, so on and so forth. This is very interesting, complex, yet highly coordinated structure of our NHS. Into the polls, yeah, there is a poll now. So, have you ever experienced conflicting results when seeing or analyzing same data? Can we have the poll, please? Can I see the poll results?
No, so the results are very interesting, and as we would expect, actually, from our engagement with organisations across the UK, 64% of you find that you do receive conflicting results when analysing or seeing your data. 36% say it happens, but it's rarer. 0% have said always. So that's really interesting. Thanks everyone for participating.
Oh, wow, that's really interesting. And yeah, since majority of you are getting different results using same data, yeah, this talk is all the more relevant. So another poll is whether the results from data analysis, whether the results from your data analysis or the analysis of the data that you have seen influenced your decision or opinion on the topic. So what do the attendees have to say on this, Laura?
So it shows that the results from data analytics influences your decision or your opinion of a topic. 92% of you say that that is the case. You are influenced by data analysis, and 8% of you say you're not sure. And I wonder if the 8% of you who aren't sure is because you're aware that sometimes these results are conflicting. Thanks everyone for participating.
Yeah, that could be in one of the explanations, that they already know that it could be conflicting. Yeah. So great. When you are using your results for your decisions or opinion, it all the more matters that we go deeper into the methodology and analytical tools that are used in order to make sure how to depend upon the result while making a decision. There are some examples. I mean, one is from sports, and this is also a classic example of crowdsourcing. Crowdsourcing is mainly resorted to these days in order to examine what could be the different possible probabilities or different possible results or different possible outcomes of one particular study. This study was undertaken by one organization in Barcelona, INSEAD France, and University of Virginia. And they tried to examine whether football referees are more likely to give red cards to the players with dark skin tones. Now, 61 experts in data analytics were employed for this purpose, and 29 teams were formed. 29 teams were formed. 29 teams, independent of each other, using the same data, came up with their own findings. The result is 20 studies, 20 experts or 20 analysts found evidence to support the hypothesis. That is 20 teams out of 29 teams came up with the result which said that, yes, referees are more likely to show red cards to people with darker skin tones. And 9 refuted it. They said no such evidence exists. Now, in such a situation, this is a crowdsourced method of, getting the data analyzed. But when you get 20 in favor of the hypothesis and 9 against the hypothesis, it is a very normal tendency to go by the majority. Well, that would be the first error that would be making here in statistics or in analysis. We never go by majority. It could be quite likely that 9 might be right and 20 might be wrong. It could be possible that out of 20, maybe 1 or 2 might be right and rest might be wrong. So we need to look deeper into what variables they have used, what confounds they have used, what methods they have used, these are the things we have to look into, and then check which is the most appropriate method, which is the most appropriate model, and then go about taking a decision on whether to refute the hypothesis or otherwise. Here's another example from psychology. This was also, undertaken by some, not able to actually, it was European School of Management and Technology, Berlin. So they had two hypotheses. One is women are more likely to participate in a debate when there are other women who are participating in the same debate. And the second hypothesis is that high-statured participants are more verbose than compared to those who are not. Again, this was crowdsourced, and very interestingly, 50% for each of these hypotheses, 50% found evidences to support the hypothesis, 50% refuted it. Even if we wish, we can go by majority here because it is 50-50. And yes, therefore, we need to look into each of this analysis and see which is the most robust and which is most logical in order to go ahead with whether women are likely to participate more in debate when there are other women, or whether the high-stature participants are more verbose compared to the ones who are not. Now, medicine is also replete with such examples, and in the poll, majority of you said that you have come across such examples where the same data gives different results. But one very interesting, thought-provoking is a study by Fisher. But before that, we have one more poll. Do you trust research findings and data analysis?
Thanks everyone for sharing your thoughts. So we can see again, 62% of you say sometimes, 23% of you say yes, and 15% of you say no, you do not trust research findings and data analysis.
Oh, okay. So sometimes, that ideally should be. Sometimes you should trust, sometimes you should question. Very true. Great. And I think we have one more poll. Do you believe that smoking causes cancer? So you can take this poll as, does smoking cause lung cancer?
Unsurprisingly, 85% of you say yes, but 15% of you still aren't sure if smoking causes cancer.
No, that is, perfectly fine, because, majority are of the belief. I had also read that majority believe that smoking causes blood cancer, but there are people who say that they know people who smoke, who are chain smokers, and nothing has happened to them, and therefore it is not necessary that smoking does cause lung cancer. So 15% saying no is quite justified, not a problem. And Fisher is one of you, 15%. Fisher is one of you. Fisher also didn't believe that smoking causes lung cancer. Fisher is the father of statistics, and still he believed. He was not a medical doctor. But what is more intriguing and interesting about Fisher's cancer controversy is that, and it is even published in the Centennial Review of Arts and Science, he said that it is not smoking which causes lung cancer. He talked about the causality. Now, this is also important. What is the cause and what is the effect? That also requires to be understood. At times, in observational studies, we come across examples or situations where we are not sure what is causing what is the cause, what is the effect. There are associations, but cause-effect aspect could be missing in observational studies at times. And this is the advantage that Fisher took. I don't know why, but Fisher said that it is not smoking which causes lung cancer. It is the genetic difference between the people who have a tendency to smoke and those who do not have the tendency to smoke. that causes, that distinguishes a smoker from a non-smoker. And it is this genetic difference which causes lung cancer, not smoking per se. It is this genetic difference to which, which makes a person prone to lung cancer. And because a person is prone to lung cancer, he has a tendency to smoke. So you're getting the point. Normally we think of habit as a cause and cancer as an effect. Fisher questions the very causality. Now, whether this is right or wrong, or we are not going into the debate of that, but this could also be possible that sometimes something that we might consider as a cause might actually be the effect, and vice versa. So that also requires to be taken into consideration when we are working with data, especially observational studies. Experimental studies, the cause and effect is relatively clearer, and in clinical trials and all, we really know what we are inducing, or what we are trying to control. And I'll be coming to it in the diabetes example. Coming to the case studies now, the very first case study is of hypertension. You know that in England, 31% of men and 26% of women have high blood pressure. And so far as diabetes is concerned, more than 4.9 million people in UK have diabetes. 13.6 are now at an increased risk of type 2 diabetes in the UK. These are some of the statistics before we move on to the case studies. This is one of the most often quoted studies, and also the basis of the normal blood pressure, as it is called, the studies on which the threshold of normal blood pressure is determined. This is a study which is undertaken in the Framingham city of USA. It involved a cohort of 5,209 participants in the age group of 28 to 62 years who were residing in Framingham between 1948 to 1951. Simple linear logistic regression was used to examine whether simple linear logistic regression was used to examine whether high blood pressure, the deaths because of cardiovascular diseases, because of high blood pressure, the threshold basically, what is the threshold beyond which the deaths are caused. So yeah, coming to the next poll, reduced spline, I'll come to it slightly later, but let's come to the next poll. What should be the threshold, the systolic pressure, systolic BP, blood pressure to start the medication? While I think we have put in 130, 140 higher as the possible answers. You might have some other answers in mind, but you can select the one which you find your answer is closest to.
So we can see that 36% of you aren't sure. 36% also think that the threshold should be higher than 140. 27% think that it should be 140, and none of you think it should be 0, based on the research and the analysis you may have come across to date.
Okay, it would have been really interesting to have a face-to-face discussion on what is the reasons for these answers, but somehow this is the limitation of technology, and we cannot ask them what makes them think that it should be higher, or it should be 130 or 140, or depends. Yeah.
But we
answer.
we do welcome you to share your thoughts on that in the comments box or in the chat box on GoToWebinar. Share your thoughts. Like, why did you make that decision? Was there something that made you believe that? Did you go on gut instinct, or had you seen something in particular that really swayed your decision on the matter?
Yeah, we can have that. Certainly. And those who wish, they can please write in the chat box. So the answer is 130 millimeter of mercury, mmHg, as it is measured. But who determines this? Or what is the basis of determining this 130 mmHg of systolic blood pressure being the threshold to start medication? It is this Framingham study. I am not saying this. I'm not even authorized or qualified to say what should be the normal blood pressure or what should be the optimum blood pressure. On the basis of this Framingham study, that the Joint National Committee on Detection, Treatment and Evaluation of Hypertension, the 6th report of this committee, recommended that systolic, I'm reading out some excerpt, that systolic blood pressure less than 130 mmHg should be considered normal, and the systolic blood pressure less than 120 mmHg should be considered optimum. Not only the 6th report of this Joint National Committee recommended this, WHO and the International Society of Hypertension even accepted these standards. And the methodology of Framingham study was robust. There was no question. There were enough number of participants. There was a long period over which the study was conducted. The data was collected, appropriately, nicely. There was no question of, questioning the data. Sometimes you even need to question the data. But everything was just perfect. And there was no reason to question this Framingham study's thresholds. But several years later, in 2000, Sidney Port and a couple of them came up with a different method of analysis. And this is where you see they applied reduced blinds. Reduced blinds means they saw that up to a certain extent, irrespective of whatever is the systolic blood pressure, the death rate remains constant. If you see the left-hand side figure, which is produced from the study of Port and his colleagues, they not only come up with different thresholds of systolic blood pressure for different age groups. And this is another, there are some doctors who believe that the threshold of systolic blood pressure changes with age. With higher age, you might have a higher threshold of blood pressure. There are some doctors who believe that, and some doctors who believe that no, it has to be 130. If it's more than 130, medication should be. But Port and others, they came up with several thresholds separately for men and women. I still don't understand why men and women should have different blood pressures, or what is the basis of deciding on different thresholds on the basis of gender. That if any one of you can explain me, I would be happy to learn. But yeah, a lot of studies segregate persons on the basis of their gender. And that is what Port and his colleagues also did. So there were two aspects that were taken into consideration which Framingham study missed. Not completely missed, but they didn't take into consideration while deciding the thresholds. So this Port and his colleagues, they came up with different thresholds for different age groups and also for men and women. They compared the threshold of original Framingham study with their own study for the age group of 55 to 64. And do you see this shaded area? This shaded area constitutes 30%. Now, according to the old Framingham study, 130 is the normal blood pressure. For people in the age group of 55 to 64, 140 could be considered normal blood pressure, but Port and his colleagues found that it is still aggressive. This threshold of 140 is aggressive, and up to 150 in this age group could be considered normal. 150 to 160 could be considered high, and 160 onwards, it would be hypertension. Now, the difference between these two studies comes up with 30% of people who are given medications which could be avoided. 30% of the people who have to regularly visit the doctor to get their pressure checked, that could be avoided. The burden on NHS could be reduced. Of course, I was supposed to ask you one question, which I already answered, but doesn't matter. Let's have that poll nevertheless. Will you reconsider the threshold BP after looking at the figures?
44% of you say yes, you will reconsider the threshold now for starting medication based on the information that Smruti shared. 11% of you say no, and 44% of you still aren't sure.
Don't worry, if you're not sure, we are there to give you consultation. I would also have gone by those 53%, 36% who said that, yes, I will change. Because this model, being trained in statistics, I would say, is comparatively more robust in comparison with the linear model, the simple linear model. So, yeah, implications I have already discussed. I discussed a couple of slides which I was supposed to discuss after the poll, but these points I have already discussed, so I'm not reading it out. Key observations are, on the basis of this, is that this case is that a change in model could result in different, could produce different results. Confounding factors like age and sex could also influence results, as we saw from this case study. Including an interaction term, age-sex combination, could also influence results. Of course, this study doesn't take into consideration the combination or the interaction term. They take age and sex separately. So holding for sex, what is the threshold for age? Holding for age, what is the threshold for sex? But an interaction term could also influence the result, and we need to check whether the interaction is statistically significant or not. Yeah, I was also supposed to talk to you about the difference between same data set and same data. So far as case study 1 is concerned, it is the same data set that was used in the original Framingham study. The same data set was used by Port and his colleagues, Sidney Port and his colleagues. But the second case study that we are going to see would be same data. I mean the data on blood sugar levels, on blood sugar levels on the basis of different medications that are given to control the glycemic level. So the data is essentially on the glycemic level, not necessarily of the same persons, not necessarily of the same type, but same data. So there's a difference between same data set and same data. But before I move on to case study 2, I would also like to point out that at times it might happen that you have different data and you end up getting the same results, just opposite of what happened in case 1. That is, same data, different results versus different data, same results. And this is a seminal study of Enscombe. This is a small data set which was developed by Enscombe to demonstrate principally the use of scatter plots before undertaking regressions. So here's 4 sets of predictor and outcome variables. YA, YB, YC, YD are all outcome variables, and XA, XB, XC, and XD are all predictors. So the regression, simple linear regression, is performed on all 4 of these data sets, with Y is equal to A plus BX, all 4 resulting in an R square of 6.67, and all 4 resulting in an equation of Y is equal to 3 plus 0.5x. But if you look at the patterns in the data set, and this is why it's important to have a look at the patterns. XA, XB is explained by the patterns in the data of XA, XB is explained by figure 1. The pattern in XB, YB by figure 2, which is parabolic rather than linear. The first one is okay, it can fit a linear regression, but here you have to go for a parabolic term. Third, essentially linear, but there are outliers. There is an outlier, and if you remove the outlier, the dot which appears on the higher side, it could have a different slope and a different intercept altogether. And figure 4 shows that there is no variation except one single observation, and therefore there is no point in fitting the regression. There is no influence of X whatsoever on the values of Y. So this is also possible. Now, when you have only 2 variables, you can have a scatter plot, but when there are more than 2 variables, there are ways and means of examining the association, and machine learning could be one of the aspects, one of the solutions to examine what could be the relation between outcome variable and the predictors. Now I come to case study 2. Now, here I have compared a couple of studies, not just 2 studies as in case 1, where the data set was essentially Framingham data set. One was undertaken by, one was the original study and another was by Sidney Court and his colleagues. But here there are a couple of, studies, of which some are observational studies and some are randomized control trials. As I mentioned earlier, sometimes it is not possible to have a clear idea about the cause and effect relationship in case of observational studies, because we just see, we do not, experiment anything. We do not hold for other factors and check the impact of one thing on the other, which we essentially do in randomized control trials. So, in case of observational studies, all these studies examine glycemic control with diabetic complications. In case of observational studies, all the studies unequivocally came up with the result that glycemic control is associated with reduced diabetic complications. So that if you control the blood glucose level, it reduces diabetic complications. Now here the question should be, how is blood glucose controlled? Second, what is meant by diabetic complications? And therefore, when RCTs were performed, it gave mixed results. So, okay, yeah, and definition of diabetes is also important. So, all the studies in RCTs focused on type 2 diabetes. Okay, so these studies are comparable. Then how is blood glucose level measured? By the HbA1c, that is average blood glucose level for past 2 to 3 months. Okay, so that is also comparable. All the studies based on type 2 diabetes, all the glucose levels are measured using HbA1c method. So these are comparable studies. Method of control. Some studies used metformin to control type 2 diabetes. some studies used insulin to control diabetes. Now, metformin can have side effects. And in fact, one of the very old studies used even fenformin. Fenformin is now banned because it results in some complications which are fatal. So fenformin, one of the studies used fenformin, which is of course now banned, and therefore that study doesn't hold any relevance in the current situation. But there are other studies who use metformin. Now metformin can have side effects. I'm not sure. Can have. Metformin, insulin can have another side effects. So whether these side effects are controlled or not, that also requires to be understood, and therefore the method of control also matters when you compare the studies or the results. Now, diabetic complications. Some studies focused only on cardiovascular complications because of diabetes. And sorry, not because of diabetes, but in diabetic patients. And another studies, some other studies, they focused on microvascular complications, like its effect on kidney or its effect on eyes, the vision, and so on. And there are some studies who also took into consideration that some people have diabetes as well as hypertension. So medicine of hypertension is also going on. They are also on medication of diabetes, and whether the cardiovascular disease or the cardiovascular complication is because of hypertension or because of diabetes, how to separate the effect of one or the other. So here, these are all basically methodological definitional complications that I'm bringing to fore. The seventh and the last goal, and of course I will not take more time of yours now.
So the question was, can cardiovascular disease be considered a microvascular disease? 67% of you are unsure, and it's even 17% of you say yes, whilst 17% of you also think no. So evenly split there between the yeses and nos, but the majority are unsure.
Okay, yeah. And it is good to be unsure, because you cannot say with certainty that cardiovascular disease is a microvascular disease. Even in the medical literature, if you read, these two are used as separate terms at times, and sometimes they are used as one. I'm coming to the robust landmark study, which is the United Kingdom prospective diabetes study, where 5,102 patients with newly diagnosed T2 type 2 diabetes. See, the previous studies didn't mention whether they were newly diagnosed patients or they have been taking medication since several years. These also affects when you are undertaking a study. All have to be new, all have to be at the same level. And what is the base blood glucose on which you are giving the you are giving the treatment? How much higher is it than the required level? And what treatment are you giving? What is the milligram of medicine that you are giving, or what is the ml of insulin that you are giving? And what is the frequency of taking insulin, or what is the frequency of taking metformin? All this influences your results. The cases in this UK prospective diabetes study, the cases were of the people between 1971 to 1991. They were followed up to 10 years. This is what makes the study really robust since the diagnosis of type 2 diabetes. There were 3 treatment groups. One group on whom sulfonylurea drugs were administered, another group on which metformin was administered, and third group on which insulin was administered, and compounding effect of hypertension and use of SE and beta blocker was also taken into consideration. This makes the methodology really robust. It clarifies what are the treatments, who are the people, when the diabetes was diagnosed, what stage of diabetes they are at the moment. And then, of course, the people, the patients on whom these different categories of drugs are administered, they have also specified the base glucose levels from of those patients on whom these different categories of drugs are administered. So key observations over here are there. It is important to understand the definitions, or it is very important to clearly define the variables before examining the associations. Change in definitions would result in different results. Coming to the summary, as I said, the first half of the summary I will be discussing, and then I'll pass it on to Laura. That it is very important to check whether the methodology and the methods used for the study are robust or not. If they are not robust, you need not change your decision on the basis of that study. You just need more information. Clearly understand the variables and its definitions, and only if the clarity is there, proceed further with that. Check whether the statistical methods used to examine association are appropriate, and whether any other methods could be used to examine the same association, and what could be the impact on the results on the basis of change in methods. Examine whether there are any confounding variables and how they are modeled. Model specification is very, very important. Measurement, as I mentioned, in case of what is the base glucose level on of the patients on which metformin is administered, or the base glucose level on which insulin is administered. Measurement is important. And in nature of uncertainty, as I mentioned earlier also, that machine learning approach can be adopted. And yeah, that's all for today. Thank you very much for sparing your valuable time. Thanks to all the participants. Once again, I thank Emma, Laura, HTN. Thank you very much. Over to Laura.
Thanks, Smruti. We've got challenges and solutions. You can also reach out to your partners, which include us, for grant-funded research and data analytics support. And then don't forget, you've also got NHSX. You've got what used to be Public Health England, but is now the UK Health Security Agency, NHS Digital, Government, and NICE as well, all providing analytics and research for you to delve through. We do have time for questions, so before we move on to that, I just wanted to again highlight these other opportunities for you to benefit and to find out more online. I know we're running slightly over time, so thank you so much everyone for joining us. And I'm going to open it up now for any questions that anybody may have. Emma, feel free to read these out, but we've also had a few submitted through ahead of today's webinar, but please post your questions in the comments bar. Thank you.
Thank you very much, Laura, and thank you very much, Smruti. That was a great presentation. We have had a comment to say thank you for your presentation. It was great. So thank you very much. If you do have any questions, just pop them in the question area, or if you think of any later, you can send them on to me, Emma at HTN, and I'll forward them on to Laura. I've just got one come to me now that I can read out for you. Thank you for the amazing session. During the session, we talked a lot about threshold and robustness checks. Aren't they often influenced by our professional biases? Sometimes even in statistics, we have some uncertainty that could lead to application biases.
Well, yeah. The answer is yes and no both. Yes is because we all are humans and we all have inherent biases. It could be biases because of our profession, or it could be biases because of our culture or because of our upbringing or whatever, but we all are bound to have some or the other biases. Secondly, so far as professional bias is concerned, it could either be professional bias or it could be professional insight. It depends whether to call it a bias or to call it an insight. But it is always better to work in a heterogeneous group wherein you have people from different professions who are qualified. Some are exclusively methodology experts, some are exclusively statistics experts, some are exclusively from your own profession, and that could help in reducing bias to quite an extent, if I have answered your question.
Perfect, thank you very much. We haven't got any more
We do have one question here that have just come in. In the slide you highlighted some of the areas of the NHS that use data analytics results. Where do you believe the most opportunity now lies?
COVID-19? Sorry. Yeah, that's a good question. But so far as healthcare is concerned, I personally believe that each and every aspect of healthcare is equally important. And therefore, there should be nothing like, opportunity. There are some areas which are well established, which you already know. But all the issues that are associated with the change in lifestyle, for example, diabetes is a lifestyle, perhaps, if I'm not wrong, is a lifestyle disease, or hypertension is more to do with the stress, managing stress. So, yeah, and mental health is a challenging issue these days. COVID-19, for sure. These are some of the issues which I find that they are challenging rather than calling it an opportunity. They are challenging, and doing meaningful research and coming up with socially useful outcomes could be helpful to the society. Thank you.
I agree. I think it is around public health as well as pandemic management. I think there's so much we could do to help communicate research and data more effectively to empower individuals at a community level to help do some disease prevention here when it comes to lifestyle related diseases. And then I've just got one more for you. Currently, it can take 10 to 20 years for research findings from data to change practice in healthcare. As a researcher, how do you feel healthcare professionals and analysts can improve this process so that patients can benefit from evidence-based healthcare without this 10 to 20 year wait for things to change?
It's important that we come up with results faster to help the community at the earliest. The concern is really genuine, but it completely depends on the nature of the disease, the fatality associated with the disease. In COVID-19 context, I would say how much immediate action is required to be taken place. If we just take the example of the vaccines that are developed for COVID-19, yeah, we didn't have the time to test for 10 or 20 years. It was in less than a year that we came up with vaccines, some trials were undertaken and vaccines were administered. So depending upon the complexity of the disease and the urgency of coming up with the treatment, I think the duration should be decided. You have to choose between how fast you want the results and what amount of risk you are willing to take. It's quite likely that higher risk would result in higher benefits. It could also result in higher losses. And here, losses means loss in terms of human health or fatalities. So there is no clear-cut answer to how to reduce the time gap, but it could be dependent on how urgent action requires to be taken place. Otherwise, robustness should be focused on. That's what I believe. This is completely my own thinking and belief, if you agree. Thank you.
Great, thanks so much. That's all the questions we've got at the moment. I think we'll have to save any more for another time. Maybe we could do a whole Q&A because we've had so many come through individually. It's such a debatable topic at the moment, because data is becoming more and more a prominent part of our lives and an important part in healthcare. We want to make sure we're using it correctly to make sure that our patients get the most they can from the insight that this really important information can give, and dispel some myths and create some clarity and challenge some data dogma, if you like.
Right. Thank you.
Thanks again to everyone. I'll hand it over now to Emma.
Perfect. Thank you very much, guys. Yeah, we haven't had any more questions this end. Thank you very much for sending them to Laura. If you do have any more, just send them over to Emma at HTN and I can forward them on for you. Thank you very much for joining us. Our next live session will be at 1 p.m. with Cardiff and Vale UHB on eye care digitalisation. So we'll see you at 1 o'clock for that live presentation. But thank you very much, Laura. Thank you, Smruti.
Thank you.
Thank you, everyone.
Thank you. Bye.
Business and Local Government Data Research Centre, bringing data to life. Exploring data, enhancing knowledge, empowering society. Whether you are a business, charity or public sector organisation, we can help you use data to improve your work. Find out more about our free support online. Visit blgdataresearch.org or click the link in the description.